Bismillahirrahmanirrahim. First talk of today is shoulder joint. Musculoskeletal ultrasound was started in 1980s, and we have different associations in the world like American Musculoskeletal Ultrasound Society and Pakistan Musculoskeletal Ultrasound Societies, working for the establishment of this modality. So let's talk about shoulder ultrasound. Musculoskeletal ultrasound of shoulder, we will be discussing about gross anatomy, ultrasound anatomy, routine examination and pathology. First of all is the normal shoulder. It includes skeletal anatomy, soft tissue structures, ultrasound images and techniques. In anatomy we can see there are different bones. The most important bones are three bones: the clavicle, scapula and the head of humerus, which form different joints. Then we divide shoulder into anterior and posterior compartments. In the anterior there will be coracoid process, humeral head, bicipital groove, greater tuberosity and lesser tuberosity. This is greater and lesser tuberosities, and anatomic neck with a acromioclavicular joint. Then the posterior shoulder comprises of infraspinatus, glenohumeral joint, humerus, bony glenoid and the labrum, sphenoglenoid groove. While scanning we look at these areas. We put our probe here and we look for different type of muscles and tendons. We look for the joint. This is AC joint, acromioclavicular joint, and here we can see subacromio subdeltoid bursa. This is deltoid, head of the humerus. Here is the labrum and the tendons of supraspinatus and infraspinatus. While scanning this area we will get this type of view. Here is the bone which is here. This is cartilaginous area. Then is the tendon of supraspinatus and deltoid. This is area is subdeltoid, subacromial bursa will be here. While scanning the shoulder in this position, when we move it a little bit to the lateral side, to the corner of the shoulder, we get the labrum. This is the area. If we scan this area we will get this type of view. Here is the labrum. The long axis and short axis of the shoulder joint. Then comes the techniques with pathologies, shoulder pathologies. For evaluation of the patient, the first thing is clinical examination followed by ultrasound. If we find any pathology of the soft tissues, we don't need any other modality to confirm it. But if there is suspicion that the bones are involved, we can go for X-rays followed by MRI, CT and arthrography. Evaluation of the patient is very important. Here is a patient in which there was no rotator cuff, and this is deltoid adjacent to the bone, so supraspinatus and infra are not there. In shoulder the main indications are rotator cuff tears, calcified tendinitis of the cuff, subdeltoid subacromial bursitis, biceps tendinitis or tenosynovitis, dislocation of biceps tendon, glenohumeral effusion, impingement syndrome, acromioclavicular joint and suprascapular ganglion cyst. So we look for all these things one by one while having shoulder ultrasound. The clinical presentations: patient presents with a dull chronic pain in shoulder. These patients had difficulty in sleeping on one side or the other. They may present with complaints of inability to comb their hair or lift arm above the shoulder like this. MRI and contrast arthrography have been the primary radiologic examinations used to evaluate to the rotator cuff. Here is contrast arthrography. A dye is there. And however, high resolution real-time ultrasound has been shown as an alternative means of examination and screening. There is a shoulder. You can see the deltoid, some fluid. The subacromiosubdeltoid bursa, this is clavicle, shoulder at MRI, and when you compare it, this area with ultrasound, you can see the same fluid in subacromiosubdeltoid. This is the deltoid muscle, greater tuberosity and fluid, and you can confirm it on the other axis. There are two criteria for sonography of shoulder: major criteria and minor criteria. The major criteria includes whether the cuff is absent or present, cuff atrophy, echo poor defects, and focal hyperechoic defects. Whereas minor criteria includes abnormal fluid, naked tuberosity, cartilage interface, and deltoid herniation. For major criteria, absent cuff and echo poor defect are more important. Here we have hypoechoic tendon defect. This is the tendon, two sides of the tendon. A small area is showing continuity, whereas most of the part of the tendon is showing discontinuity. So this is maximal partial tear of the tendon, which can be confirmed. Absent cuff, as the deltoid is in contact with the humerus. There is no tendon in between that, and it was confirmed on the other axis. Coming to abnormal fluid, it can be in subacromiosubdeltoid bursa, the long biceps tendon, and glenohumeral joint with a acromioclavicular joint. We look for fluid in these areas. For subacromiosubdeltoid bursa, you can see the fluid there. This is deltoid, and here is fluid in subacromiosubdeltoid bursa. This is humerus. Here is again a more clear image showing fluid with thickened wall of the bursa. This is long biceps tendon, and fluid around the long head of biceps in short axis, and in the long axis you can see fluid around the tendon. Full thickness tear. At real time you can see this clip, and there is full discontinuity of the tendon. So tendon is torn. You can see the gap between that. So full thickness tear of supraspinatus. We can have partial thickness tear, but partial thickness tear is further divided into bursal surface partial thickness tear, intrasubstance partial thickness tear, articular surface partial thickness tear, and rim rent type of tear. In intrasubstance, you can see this area is showing some tear, this some sprain, which was confirmed in the other axis. Then comes the articular surface. There is continuity, but we can see discontinuity of the articular fibers, the fibers which are near to the joint, and it was confirmed on the other axis. So full thickness tears, the sensitivity is 97%, specificity is 100%, positive predictive value is 97%, and negative predictive value is 100%. The sensitivity For partial thickness tear is 94%, specificity 94%, positive predictive value is 85%, and negative predictive value is 98%. Here we have a case of tendinitis. In chronic tendinitis, you will see the irregularity of the tendon along with calcified areas. There is a calcification, another small calcification, and a large calcified area within the tendon. Here we have another scan. We can see multiple calcified areas showing chronic tendinitis. For posterior labrum, we scan the patient sitting in this position, and we scan from the back. We put our probe at the back of the patient, and this is posterior labrum at long axis. A panoramic view for infraspinatus scapula. This is suprascapular nerve along with the ganglion and a ganglionic cyst which was confirmed on CT and MRI. So in conclusion, we can say that rotator cuff diseases, full thickness tears, major and minor criterias, effusions, impingements can be diagnosed by scanning musculoskeletal for scanning the shoulder. We have 5 types of lectures on shoulder, and I will try to deliver that whenever I get time in future. Thank you very much.